Good morning. So this is a vlog on the surgeons who I know, who I've assisted with on operations, and the ones that I know of or read their books, work, or learned of, mainly as a medical student and intern, and also as subsequently after medical school and internship. So the first surgeons who I actually knew were two that were with my family, and the first is Cyril Fletcher, which is a uncle of my mother, and a general surgeon at the University of West Indies, who my mother told me of, and who I met, and still see when I go back home on vacation to Kingston. The second is Gregory Thomas, who is the cousin of my father, who's also a general surgeon. He was an attending at Cornwall Regional Hospital, and someone who I also spent a lot of time with out in Kempshot, near Montego Bay. After that, I did meet surgeons through some personal procedures that I had done on me. One was an orthopedic procedure for a bone cyst on my right heel, for which I met two orthopedic surgeons. The first one that I didn't select for that operation, the second one who I did, whose name was Scott something. And then my first opportunity, or the first time that I actually assisted on a procedure, I was 18 years old, 18 or 19 years old. I was in, Montego Bay, Jamaica, and courtesy of Gregory Thomas, I was able to assist a Colombian surgeon who was working at Cornwall Regional Hospital on a hernia repair for a young black Jamaican, so a young boy. At that point, that was just before my sophomore year of college during the summer. And for that procedure, I actually got to scrub in and do a little bit of assisting, even though I was just a undergraduate student at the University of South Florida at that point in time. And then as a college student at USF, I also got to shadow and view a lot of operations at Shriners Hospital. I volunteered at Shriners Hospital for 3 years in the surgical units, and got to see a number of procedures. I didn't get to assist or didn't scrub in, but I got to stand in the operating room and watch for like 3 to 4 hours after a day of school or day of class. For instance, one procedure that I saw there was a correction of a woman with kyphosis, some severe kyphosis, which was an issue with her spine. She was probably kyphotic and lordotic or something. And so he actually put a steel rod in her spine, all the way from the cervical spine or the high thoracic spine or vertebrae, all the way down to her lumbar and sacral vertebrae, to straighten her back, and he tightened it. It looked torturous, but it's supposed to be effective on some level. After seeing a lot of those procedures at Shriners, and I'm not really sure who those surgeons were. I didn't really introduce myself. I didn't really get to see any of the surgical notes or anything like that because I was not, working there, and I was not a student, like a medical student. But so after that, then, I didn't really get to see a lot of procedures until, my third year of medical school. I mean, at Shriners, I got to see, it was one or two a week kind of thing for some periods of time. But it wasn't really till my surgical rotation, where I really got to assist and start to learn about general surgery in much greater detail. The first surgeon that I operated was a black woman, I was the first assist on that procedure, and it was a total mastectomy for some type of breast cancer, during which I was mainly doing some retracting. She would like set these little pins, which I would hold and kind of put a little tension on and pull back on, as to kind of assist her with the the removal of the breast tissue. So all of these actually procedures were at the Brigham and Women's Hospital, because that is where I did my 3rd year surgical rotation, which is up here in Boston. But anyway, that woman, she was the one who told me to get an atlas. And as a result of that, I bought Zollinger and Zollinger, which is an excellent atlas. It was the one that looked the best to me from the selection that I saw at the Harvard Coop at that point in time. And so that's what I bought. It made a big difference. I started to really appreciate some of those procedures and what they were doing a lot more, because I could see it in pictures as opposed to just reading it in words or listening to what I was being told. But I quickly selected to work with Robert Tilden Osteen as much as possible. He was an older man, probably in his about 70s. He was very experienced, clearly knew a lot, as all the surgeons do. But I mean, he was so experienced. He was kind of like very much a senior surgeon that a lot of the younger surgeons looked up to. So I tried to operate with him as much as possible. I don't recall every procedure that I did with him, because pretty much if he was in the room and I could get in there, I would go immediately. But I did get to be a first assist on a whipple, which is a really big procedure in the surgical oncology world, that he did. It's also known as a pancreaticoduodenectomy. And, that was for a patient who had pancreatic cancer. It's usually, I guess always actually probably at the head of the pancreas, which is a daunting procedure, and it's a daunting diagnosis, because pancreatic cancer is often caught very late in the stages of cancer, because there often aren't many signs or symptoms of that cancer early on. So they typically present once it's rather large and pressing on the duodenum, which causes some satiety, like early satiety, or they sometimes even present with metastasis, because it's already that late in the stages of that cancer. I also got to operate with Atul Gawande. With him, it was only one procedure that I got to do. I actually saw the patient before we went to the operating room, got to sit and listen to him do his history of that patient and gather some more information as he was preparing her for this procedure. It was for pancreatic cancer, not pancreatic cancer, but rather parathyroid cancer. And so he did a parathyroidectomy. If I recall, I'm pretty sure he left a little part of the parathyroid either right behind her thyroid. I'm pretty sure he did not graft it to her arm, which is what some surgeons do. They graft a little bit of the parathyroid to their arm, which assists with ensuring that they have proper calcium metabolism. But that was a parathyroidectomy. And Atul Gawande is, pretty much is as a well-known surgeon, one of the most famous probably from the Brigham, and he's written a lot of books like Complications and Better, and he has a couple others, I think. But he definitely has a lot of papers. He focuses on surgical outcomes and processes for reducing mistakes as surgeons, which is a very important process, something I had to really appreciate and understand, because it is so different when it comes to operating and being a surgeon as opposed to being a soccer player, footballer, footballista. As an athlete, especially in that capacity, we can make umpteen mistakes on the field and we're not really killing anybody except maybe ourselves. But when it comes to operating, you really have to know what you're doing, and you really have to know when you make mistakes. And if they're preventable, that's great. But I've found in my own life that it's very difficult sometimes to prevent mistakes, because that's just my human nature to do something a specific way. So I've started to, instead of trying to prevent every mistake, I started to slow down and identify mistakes, and when I make it, be clear to correct my mistakes as quickly as possible, or at least be very cognizant of those, which is a very conscious process. There is no doubt about that. So I also operated with Monica Bertagnoli. I did one procedure with her. I was a first assist. So let me just tell you, when I say first assist, what that generally means in my case, because for most of these I was medical students, is that it was just the attending and I in the operating room. Because what typically happens is when there's a resident, the resident and whoever's the most senior takes the precedence. So the attending is the operator, and when the attending is there, the senior resident would be the first assist, the junior resident would be the second assist, the medical student would be the third assist, and then, there's surgical technicians who might be fourth or fifth, or, considered higher than some of them depending on the experience of the resident or student. So for all these procedures that I was first assist on, it was just the attending and I in the room. And then if the attending's not in the room, the senior resident is the main operator, and then, everybody else just gets bumped up as an assistant. So for instance, there was a time where I operated with a resident. The resident did most of the procedure, and I was the first assist to the resident because it was the resident and I. And I'll tell you about that procedure in a little bit later. But anyway, back to Monica Bertagnoli. So she was also a surgical oncologist, and she did a removal of a sarcoma. And so I assisted her with that. Again, it was largely just retracting. That's really the main thing I was doing for most of these procedures, some retraction, which isn't the easiest thing. You do have to kind of understand the anatomy, understand the tissue, understand the effects of pressure on the tissue, because you can kill the tissue just by retracting too hard or cause death or more injury than is necessary to a patient. So I was definitely very aware of that and, very concentrating on retracting and providing a very good field of view for the operator, but also not retracting so hard and pulling on the tissue so hard in a way that would detrimentally hasten injury to that patient's body. I also got to be a first assist with Elizabeth Lesnikowski, and with her I did, I'm pretty sure it was just a lumpectomy, but it might have been a partial mastectomy, but from what I recall, it was really just a lumpectomy. I actually left the room a little bit early on that because I'd spent the day on an anesthesiology rotation, and I was very tired. By that point, I was realizing the limitations of my body and how tired I could get just from, thinking through these procedures, thinking as a surgeon, thinking as a medical student, and the amount of work it took just to support my brain in that capacity, which was a lot more than just thinking on the football field. It's like night and day, or day and night, not joking. Big differences. But anyway, with Elizabeth Lesnikowski, I actually got to do the opening incision, which was a straight line incision or like a vertical type or horizontal incision over the woman's breast, right over the lump that we removed. So yeah, I'm pretty sure it was just a lumpectomy. But it was a big, massive procedure for removal of a lump. But apparently that's what it takes. And then I got to be a second assist. And this is the resident I was talking about. So initially I was a second assist because it was the attending resident who was, I think, a fourth-year resident. This was also at the Brigham, and me, but the attending left, and then it was just the resident and I, and we both, I helped close that patient through the closing suturing, which is a very important technique. It's something you could even start learning as a college student, even as a high schooler, or whenever you're interested in surgery, although you do have to learn the anatomy, you do have to know the body, you still have to know all the physiology, you still have to get to the point where you're understanding diagnoses and prognoses, and you still have to be able to function as a doctor to be a true surgeon, not just an operator. Because when you're just an operator, you'll merely be a technician, which isn't horrible, but there is a big difference. So anyway, with that one that I was started off as a second assist on, it was a surgical removal of a very large kidney stone. I mean, I don't know if it was 9 centimeters in circumference one way, maybe, almost 15 centimeters in circumference the other way. So in length and width around that stone, it was a very large stone. It was actually the color was white and yellow. There's a specific name for that type of stone, but it was a calculi of some sort. But I think they might even call these things like staghorn to describe like the size or something. But I think, what is it? It's not oxalate. There's like 4 types, but I didn't really prepare for that, and I don't want to say the wrong thing in this situation. So after that, I also, at the Brigham still, I also did assisted on total hip replacement, on a total knee replacement, and then also with Jim Reddy. I'm pretty sure it's Jim Reddy and not John Reddy, but Jim Reddy, who's a Canadian guy who works at the Brigham or worked there, and an orthopedic surgeon. With him, I was the first assist on a revision of a total hip replacement, which was really interesting to see because he really just, it was a very quick procedure compared to some others that I saw. He clearly knew exactly what he was doing or what he had to do. He used a lot of like this wire to secure the proximal part of the femur of that patient. And he was just, he was very like, it was like he went overboard in some ways. I know he wasn't really going overboard, but to me, that's what it seemed like as a medical student. He probably wasn't going overboard, but he really put a lot of that wire right around the proximal end of that femur to secure that bone, because that's what had broken. And, she had already had one procedure, it broke again, and that's for that reason she needed a revision. And so, yeah, he was trying to secure it with as much material as possible. It really looked like carpentry at that point. It really was like installing hardware. All right, so I did that. And I also did see, also at the Brigham, a poor outcome, or at least one that I knew was poor at that point in time. This one was with David Soybell, who was also a surgical oncologist. I think he's somewhere in Pennsylvania now. And I wasn't sure for all the reasons. Sometimes the reason for these poor outcomes are more patient-specific factors, like the patient, the type of disease that they have, some things that were just uncontrollable, or some difficult anatomy or some anatomic variation. But oftentimes it's also really surgeon-related factors is what I've realized and what I now know. And this is well written about in the literature, which has to do with proper preparation by the surgeon, doing all the proper scans, knowing their anatomy, clarifying the variations in their anatomy, which exist for everyone. There's always anatomic variation. It's just how subtle is it, or how large is it? And sometimes it's not easy to pick up all those differences or to know that ahead of time. So you have to do, magnetic resonance imaging, CT scans for that information. Otherwise, you just won't know. And that will often lead to a poor outcome if you're not knowing. As a surgeon, you have to know. There's no doubt about that. If you don't know, you're going to kill the patient and you're going to lose your license. And then you can't even end up in prison. It's that serious, without any money, because malpractice, you'll get sued to the hell. And then you'll have issues. So in this case with Soybell, I don't know if he was the one that really fucked up that patient, or if, it was something that was a difficult case that he decided to take on. I didn't ask him those questions at that point in time. As a medical student, while it'd be great to ask every little thing that you think about, you kind of have to get on with it because everybody else is busy and you don't really want to get in the way, and you don't really want to get kicked out of medical school after that much work to get into medical school. But with that patient, what I do know is she ended up having to have a mesh placed over her abdominal incision, and it was for one of 2 reasons. I'm just not clear on, and it might have been both, but I'm just not clear on which one and which one was the primary reason. One reason was because he couldn't secure or approximate her abdominal tissues. So she kind of was going to need some kind of transplantation of skin or something to close up that surgical wound. And that was, I think, the primary reason from what I understood in the conversations that I heard. But it might have also been because of infection, I'm just not completely sure. Okay. Just so you know, I'll definitely put links to all of the surgeons, if not, or at least most of the surgeons, and maybe some books and stuff that might be helpful for any of the budding surgeons who want this information immediately. So beyond that, I also got to see a removal of scar tissue from this patient who had severe skin burns. These skin burns he had had for, and he'd had more than multiple procedures, like 3 to 4 procedures to remove. And then I do want to note one anesthesiologist who I saw at the Brigham, who is Malampati, and he came up with this Malampati scale that's famous. And I also got to see and assist on a prostatectomy, which is the transurethral resection of a prostate, for which they use these scopes. They put it through the prostate. It has a little cutting thing at the end. They turn that on, and they really just kill out that prostate. It just removes all of that tissue. I also saw a cardiac bypass graft when I was working with the anesthesiologist, where they cracked open the patient's chest. The surgeon did that through the patient's sternum. They, revealed or showed or the the heart. They used a bypass machine where they had to put specific ports into like something with the atria, so that like the atrial vessels, and then also through the through the aorta, I guess. And then they used cardioplasia, stopped the heart, and at that point operated on the coronary vessels of the heart. And the indication for this was severe atherosclerosis of like greater than 90% occlusion of, the coronary arteries. I think the specific indications are like greater than 90% or something of the LAD, which is with the lateral anterior descending artery. And then if you have like more than one occlusion in more than one of these coronary arteries or branches of the coronary arteries, like the circumflex arteries, or the, I guess there's also a posterior one too. That's some easy anatomy to look at. It's right there. You can even Google that stuff and find pictures to see it. I definitely know how those vessels look already. I can vision it in my brain, but, I'd still have to perfect knowing each and every term for each of those arteries. Not always easy for me, but I definitely can visualize the anatomy way better now than before medical school. And then I also saw an otolaryngology procedure also at the Brigham. So I did get to see procedures at the Beth Israel Deaconess too. And, the two that I really saw there was, so Beth Israel Deaconess Medical Center is another hospital here in Boston in the Longwood area. It's in a similar area as Brigham and Women's Hospital. I did a rotation at Beth Israel Deaconess where I got to see some procedures. And so I saw Jonathan Critchlow, and he removed a cyst, a benign cyst from a woman. It was in a specific epithelial lining of some sort, and he removed it very discreetly. It didn't leak, it didn't spill. He was able to remove the entire ball of tissue with that fluid inside it. And I pretty much just saw that one. I didn't really get to assist, but I would have been the first assist. It was just he and I for that procedure. And then lastly, at the Beth Israel, it was a gynecologic oncology procedure for ovarian or uterine cancer, which I did some assisting on for that. And I was a second assist because it was the OB-GYN oncology or gynecological oncology surgeon, a resident, and myself. It was the three of us for that procedure for the most part. So yeah, there might have been a few others that I saw, but those are the most notable. Those are what I recall quickly and what I know I've done and assisted on and seen and read of. Beyond that, I do have a large network, or I have a network of surgeons. Definitely not the largest, but I do know some surgeons, mainly some faculty and mainly classmates who have gone on to general surgery or a subspecialty. And so I'll just list some of these so you can know some of the people that I know. So it's Selwyn Olstein Rogers, Johannes Kratz, Andy Malin, Amanda Munoz, Audley Lloyd Martin Osborne, Theo Nyame, Jeremy Taylor Smith, Min Coker, this guy named Manish, not sure what his last name is at this point, but he's an Indian guy from what I recall. Dom Barkley, Marco Ellis, George Molina, Ian Dunn, Thomas Thornhill, Scott D. Martin, and Richard Scott. All right. And then what's very important, especially for anybody who's going into surgery or wants to understand surgery, is the surgeons that we know of, the surgeons who made a big difference on the field of surgery, and the surgeons that we read about because we read about them in their books and papers. And the ones that were most notable to me are Sabiston. I really enjoyed that book. I took my time and read as much of it as I could. I really started to understand antisepsis, the difference between antisepsis and clean, what specifically clean is, as well as the organization of an operating room, and also, some of the basic, a lot of the procedures, but some of the basic procedures, and also anesthesia, because obviously anesthesia was a big and very important invention for modern surgery. The other book surgeon who I obviously learned about through his writing was Lawrence, and that was what was recommended at Harvard Medical School for third-year medical students. I also learned of Schwartz, and then also Zollinger and Zollinger, which was a father and son team of surgeons, and they worked on that atlas together. I've read of the Mayos, Cushing, and Halsted. Halsted really made an impression on me. His approach really made sense, although it's probably not the smartest or most intelligent approach, to be quite honest, but it's not necessarily dumb or stupid either. But he decided that, to beat cancer, you just had to operate wide enough, remove enough of the peripheral tissues, and make sure and do a careful dissection, which is very important. But the downside of that is that he really debilitated some of his patients, even with the intention of assisting them. He created or invented a procedure called a radical mastectomy. So I read largely on that. I was definitely interested in cancer and definitely wanting to know and understand that. And while I realized his approach might have had some success, I think he himself even concluded that it was too debilitating for the patient because they couldn't really move their arm well anymore and their chest. And he also didn't necessarily always end up with a cure. Or he might not have ever. That I'm not really sure on, but I know it wasn't always. Otherwise, we'd just be using surgery all the time. As a result of that, we started focusing on things like radiation and chemotherapy. So that's why, to me, it wasn't the most intelligent approach, but it definitely wasn't stupid, and probably a necessary step to get to where we are now. And then the other ones are Bill Roth. I also definitely learned about Ben Carson, and that's really the majority, or if not all of them. If you have any more questions, let me know. I can definitely answer you. If you have any questions about surgery, I'm definitely willing to assist. If you need either an assistant for something, let me know. Or if you need tutoring or mentoring, just let me know. If you have any specific questions, you can leave them in the comments, or you can also send an email directly to me. And you can also call me at this point because I definitely have time to take calls. So I'll leave links below that I think will be helpful for any budding surgeon or even surgeons who are just struggling and need some assistance. And probably medical students and college students will find this helpful. But I definitely think starting in high school, if not even a little bit earlier, when you want to be a surgeon, will make the difference, because it's kind of like sports in that arena. The earlier you start, the better you should be with the proper guidance. If you start too early and don't know what you're doing, you'll just get confused and even go crazy and insane, maybe. But if you start early and you have proper guidance, mentorship, and you know what to do and you listen, then you probably will excel beyond belief and beyond most people. So I'm definitely willing to assist you all with that, regardless of where you're from, what country you are, what race you are, what religion, and if you have no religion. And just so you know, if you want to know my religious point right now, and probably for the rest of my life, I'm definitely Catholic atheist. So for me, I don't believe in God. All right, if that's a problem, just let me know. But anyway, I'll definitely be in touch, and I definitely hope you find this very helpful. Comment, like, subscribe.